comments. Welcome everybody to mental health support for the healthcare workforce. A lot of you have been with us these past few months, so welcome back. To those who are new, welcome as well. I'm Jody Dvorkin. I have my colleague Tani. Do you want to say hi, Tani, on the line as well? She's been leading this with me.
Hello all, good to see you.
And we are really excited to have Dr. Scott here with us today. Before I introduce her, just a few reminders. We are doing Zoom. We know it's lunchtime, so feel free to eat, do what you need to do, but turn on your videos if you feel so inclined. We love to see faces. Go ahead and mute yourself during the presentation, but you can chat in questions throughout. And we'll pause, Dr. Scott, if we feel like the question is kind of relevant to the current slide. If not, we'll leave the questions to the end as well. And then at the end, feel free to unmute and ask questions. We really want this to be a dialogue, and she has a lot of rich experience. So ask away throughout and at the end of the presentation. Fantastic. So I'm going to go ahead and just introduce Dr. Scott and turn it over to her. So Dr. Susan Scott has practiced kind of the art of science of nursing in a variety of clinical settings, including neonatal ICU, neonatal pediatric transport, ambulatory pediatrics, patient safety, and legal nurse consulting. She currently works as a nurse scientist at the University of Missouri Healthcare. She received her PhD in nursing sciences from Sinclair School of Nursing, and her research interests involve the development of institutional support networks to address clinician support in the aftermath of emotionally challenging events. Thus, obviously, why we wanted her to come talk today. So she has done a lot of research around the second victim phenomenon, allowing for the design and deployment of the first of its kind peer support network, the forYOU team that she'll talk about in our presentation today. Through dissemination of 40 peer-reviewed articles, textbook chapters, and national and international conference presentations. Her research findings reach a broad audience of healthcare providers, patient safety researchers, policymakers, and healthcare administrators. Dr. Scott has partnered with agencies such as the Agency for Healthcare Research and Quality, American Hospital Association, the Joint Commission, the Institute for Healthcare Improvement, and the National Patient Safety Foundation. We are so thrilled. I spoke to Dr. Scott, I think now it's been kind of over a month or two ago, and I saw kind of some of their work presented on a different webinar and reached out to her, and she got back to me right away, and I was super excited to have her come and share. We spoke, and she told me more about what they were doing, and I thought it was really relevant to the conversations we've been having. So I am so pleased and thankful to have her. Dr. Scott, I'm going to turn it over to you.
Okay, well, thank you, Jody, and thank you for the invitation. This is the first post-COVID presentation I did. I was in Shreveport, Louisiana, in the middle of March, and pretty much shut everything down upon my return. So I don't think I had anything to do with that, but it's kind of how it happened. So it's nice to be with you, Jody, and thank you for that opportunity. Today I'm going to be sharing a lot of slides that share insights into both the research that we've done at the University of Missouri, as well as a little bit about the support team that we've put in place and just recently celebrated 13 years of service to MU Healthcare. So I just wanted everyone to know that these slides are available for everyone to use. I've always been very open about just using it, robbing and deploying with permission, you might want to say. And if you see slides that could help you or your team members, please feel free to take it and make it what you want. I only ask for attribution to the MU Healthcare in some way, so that could be a 4-font note at the very end of your presentation, but that's all I ask. So just to talk a little bit about medicine and where we are today. I love this quote by Sir Cyril Chandler. He's a pediatrician from the United Kingdom. And right after the initial Two Eras Human report, which was published in 2000, that launched our modern patient safety movement, he said that medicine used to be simple and effective and relatively safe. Now it's complex, effective, and potentially dangerous. And I'd like to add to his quote and say not only for the patient, but also for those well-intended caregivers that are providing life-saving support to these patients and their family members. We're learning, and especially in this era right now, the tremendous occupational hazard, the cost of caring that individuals could experience. whether you call it burnout, vicarious traumatization, compassion fatigue, moral injury, moral distress, second victim phenomenon. Basically what we're addressing is distressed staff members. And so today I'd like to just share a little insight into what we've learned, specifically focusing on the second victim phenomenon. It's interesting. When you first hear the term, you might not be familiar with what that's like, but if you've been in healthcare for a while, many clinicians have already witnessed colleagues suffering as second victims after a challenging clinical event, an unexpected medical error perhaps, or another unexpected clinical outcome that didn't involve a medical error. And sadly, what we're learning is that as people progress through their professional careers, you probably will average 3 to 4 cases of second victimization during your clinical years. And intriguing enough, when this does happen, even though it's fairly ubiquitous, most clinicians aren't really sure what they're experiencing. In fact, they're very distressed, and many feel like they could possibly be suffering from a psychological breakdown of sorts. And when they do experience that, they reach out for help by just looking at their coworkers. But sadly, the coworkers really don't know how to respond or what to do or how to assist that coworker. So typically what you find is a suffering coworker with a caregiver colleague that's next to them that's talking about the sunny weather in mid-Missouri today. They just don't know how to approach it. They're not exactly sure what to say or how to say it. And so the goal of our work is to try to figure out supportive infrastructures so that staff, understand the second victim experience, but also that they kind of know what to do to arm them with skills and knowledge so that they can move forward. I always start my presentations with a professional rating, so there's going to be a couple SUISMs involved in this presentation, and that is including the rating of E on this presentation for emotional labor. As I go through the presentation today and talk, the clinicians in the audience will probably have an opportunity to reflect on a personal case. In fact, that happens more times than it doesn't. And just what I'd like to say to the audience today is, if that happens, please just take a deep breath. You'll probably have similar symptoms that you had when the case initially happened. That's perfectly normal. But what I just like to infer is that perhaps in the context of this presentation, it might promote healing of your own case, which you didn't even realize that you needed healing for. So it's kind of an interesting effect. I'd also like to talk a little bit about a concept called emotional labor. It's interesting. As humans, we can participate in 3 different types of labor. Physical labor, which we all know what that is, and what we're thankfully starting to minimize some of the physical labor work of some of our healthcare workforce as well. Cognitive labor, which everyone in the audience today has applied so that they could learn their skill sets and be in the professions that they are today. And last but not least is a concept called emotional labor. And it's probably the most intense, most difficult labor that humans can do. And emotional labor is defined as it's a social science concept, and it's defined as when an organization or your employer provides you with insights on how you respond personally to an event. So you might have heard of it as on-stage, off-stage performance. If something really, really hurts badly, you still have this smile on your face and this reassuring affirmation for the patient and their family members, when deep down you realize that things aren't as good as they seem. And so the application of emotional labor sometimes actually causes more duress in the clinician that's suffering in the aftermath of a challenging event than if they just actually be able to talk about how they're feeling and what they're going through. So interesting concept that I had never heard of before I started working with social scientists on the topic of second victim. Just a few facts about the second victim phenomenon. When a clinician is involved in an adverse event, most of them, the vast majority, have troubling memories, a lot of anxiety, remorse, blame, guilt, distress. That's really probably not a surprise to anybody. I guess I was a little shocked by Hugh's study that showed that in 1 year, out of over 1,400 clinicians, physicians, that 80% of them had a patient event and within just the last year that they would refer to as distressing. I would imagine now in the COVID era that that's moved up to probably 100% within the last month. It's just kind of shows the emotional toll that these kinds of clinical experiences have. A study that I recently did showed that 50% of, about 51% actually, of traumatized clinicians actually devastated by an event aren't even involved in the case itself. That includes supervisory personnel, house managers, on the medical staff side, the attending physician when an intern or resident is involved in a case. So many of them kind of vicariously suffer as a result of someone under their watch. And then another study by SAY showed that 43% of physicians suffer from depression, anxiety, several contemplating suicide after unexpected clinical events. And this is related specifically to a medical error. As a young patient safety officer, I was exposed to these commonly heard phrases. And I won't read them to you, but I'll let you kind of look at them yourself. You could shut your eyes as a safety officer, and it could be a male or a female, or it could be a brand new rookie or the most seasoned clinician you have on the block. It could be a physician, a pharmacist, a respiratory therapist, a nurse, and they could all be saying the same things as humans. And so probably the one that shook me the most was the last one. I'm going to check out my options as a Walmart greeter. I can't mess that up. That was given to me by a surgeon who was well known in our community, a very established, successful surgeon who had made a mistake. And he was just ready to just call it quits and throw it in the towel. So maybe if you've worked with staff immediately after some of these events, you might have heard similar kinds of phrases. We, even though the term second victim was coined in the year 2000 by Albert Wu, it really wasn't defined until we did further research at the University of Missouri in 2007 and 8. And so we kind of threw a broad cast out when we defined the second victim experience as anyone within our healthcare setting that's involved in an unanticipated patient event, a medical error, and or a patient-related injury, and they're victimized in the sense that they've been traumatized by that clinical event. A study by Bush with over 14,000 clinicians in response to medical errors, looking at what some of the physical and psychosocial responses might be, found this listing or identified this listing of symptoms that they were experienced by the participants. So keeping in mind more than 14,000. I think probably if you look at the different types of responses, there's really not a surprise there, pretty much anticipated. I think what the key message that I'd like to make on this slide is that the vast majority of clinicians, 3/4 in many cases, have this kind of predictable response. So if we know that, can't we, in an anticipatory kind of manner, develop interventional strategies to help address, take care of that clinician or their coworkers? This just kind of breaks it down a little bit more, but when you have a second victim reaction, it really impacts all 4 of your personal dimensions. Physically, you might have a response. Cognitively, you might have a response, emotionally or behaviorally. And everybody goes through these events a little bit differently, but you could almost bucket them into each one of these. It's interesting that clinicians try to hide sometimes their true feelings through the application of emotional labor that we talked about later. And so I feel like the reason that peer support is so successful is because you can get behind the person. You get to know them. You know that this inattention to detail that Sue just did today isn't like Sue, or her tense posture is unusual. Maybe I should just reach out and proactively help her. So I believe that that's why the peer support model is so successful. The peers get to know each other. And if I had a coworker that would walk in the room right now that was distressed, I would pretty much know it almost instantaneously. And this program that we have gives us permission to proactively reach out and talk to those folks. A few more facts. 28% of almost 1,300 physicians involved in an adverse event declared that this had a severe impact on their personal lives, almost 1 in 5. So that's pretty telling if what happens in the healthcare environment is taken home to them. 100% of 74 pediatricians said that after a patient's death, they need and would love to have support, emotional support. Sometimes we forget that the doctors are human as well. And so we need to make sure that we take care of all of our caregivers and not just a few. And then the topic of suicide is, I think, important, especially if it's associated with a medical error that causes serious harm or perhaps even death of a patient. That the rate of suicidal ideation among the healthcare team members, but in particularly the surgeons, are about twice the rate of what we see in the general population, with females having twice the rate of males. We identified 5 key clinical events that could evoke a second victim response early on in our research. And the first one shows up almost every single time. That's when the clinician connects in some way to the patient with their own family. So it could be as simple as they had a 2-year-old grandson that visited, or has a picture of a 2-year-old grandson at the bedside that looks just like my 2-year-old grandson and same age, and oh, by the way, coincidentally has the same name. Or it could be a patient who has the same diagnosis as one of your loved family members, and they start taking on the characteristics, and you feel like that could be them. So if you talk to the clinicians after, if they're really distressed, many times you'll figure out how somehow they connected. It could be through the gift of time. So like I worry about long-term relationships with patients, like perhaps through long-term care facilities, or a patient that's going through the HEMONC experience, or could be a pediatric patient. We not too long ago had a in vitro fertilization case where the neonate had significant problems, and the provider had actually taken care of this young lady early on, from as a GYN through her marriage into her infertility years, and suffered deeply, primarily because she connected with that patient. Other cases that could evoke a second victim response are pediatric cases, medical errors, failure to rescue, especially when you retrospectively look at a case and can realize that there's subtle signs of deterioration, but because of the clinical environment and the intensity of that environment, it really wasn't noticed that the patient had this subtle decline until it was too late. And then first death experiences are incredibly traumatic, especially for our new young nursing staff and respiratory therapy staff. We try to, in orientation, actually have purposeful conversations on what that experience could be like, to normalize it so that they know that everybody kind of deals with it differently, and that it's normal to have a lot of different reactions. About 4 or 5 years ago, our team started getting more and more activations for exposure to workplace violence. So I believe that this probably would show up as a high-risk scenario if the study was replicated in today's world, as well as the COVID exposure experience has really drained the emotional resources that our staff have right now when they come to work. This is a quote from one of our clinicians that we interviewed. We interviewed 31, and we divided them up between perceived support, that they did get perceived support, or that they did not get perceived support. So this respondent actually received support from their supervisory personnel as well as colleagues. And they said, "I will never forget this experience. This patient will always be with me. I think about her often. Because of this, I'm a better clinician." What we found when we did the dichotomy of the two groups, with and without support, was that the coworkers with support felt like they had improved either care or themselves in some manner, so that they could thrive from the experience. What we learned from the other 26 that did not have perceived support, So only 5 had support in their minds. The other 26 thought of it more as a haunted memory of sorts. And if you could use your imagination with my PowerPoint skills, there should be a ghost-like image that appears on the back of this paramedic. All 31 talked about this traumatic clinical experience as staying with them. And it really depended on their perception of support, if that meant that the post-event experience was a positive or negative with or without support. We learned that there's actually a predictable recovery that individuals go through after they've been traumatized by a clinical event. And I tell folks it's not important to memorize these stages. That's not important at all. But what's important to know is that if you are trying to work with a caregiver or a team member that has just suffered suffering in the aftermath of a traumatic clinical event, to know that they're going to go through different phases, to know that they're going to need different help at different times. And so I'd like to just kind of go through these very quickly. To orient you to the slide, the name of the stage is at the top, the characteristics are on the left, and then a quote from our initial survey of clinicians suffering as second victims is kind of demonstrative on the top right. So the first stage is called chaos and accident response. And it actually happens the moment that the event, the error, the code blue, whatever is realized. It's the moment that they understand something catastrophic has happened under their watch. And it continues until they turn over the patient to another caregiver. So it could be a matter of a nurse on a med-surg floor that calls a rapid response team, the code is called, the patient stabilized, transferred to the ICU in an hour. Or it could be, in the case of in rural Missouri, we have a lot of paramedics that have prolonged ground transports, especially in our wicked winter months. And they could be a real prolonged, protracted stage. And this is chaotic was the choice we used to describe it, because the clinician, their thoughts are very jarbled. They are trying to sort out what happened. They can't quite figure it out. Many of them have said that they felt like they're doing CPR, but they're watching somebody else do the CPR while they're focused on, let's figure this out, let's sort it out. So the chaotic jumbled thought is kind of a classic for this sign. And you may have seen it yourself if you've come upon a code and you're trying to assist one of the first responders of sorts. It's the report is kind of fragmented, and it's short sentences. It's just kind of blurting out what they can think. And then over time, that starts to become a little bit easier to tell the story because they've put some meaning to the context of what's happened. Intrusive reflections is the second phase, and it's actually probably the most dangerous phase for the clinician. It starts from the moment that the care is turned over to someone else, and they can start really purposefully thinking about the care that was rendered and what's transpired up to the point of that clinical event. They tend to self-isolate, and during this time, the clinician starts planting what I would call seeds of self-doubt. They start saying things like, boy, you know, a student nurse wouldn't have done something this stupid. Or, you know, my intern probably would have been smarter and picked it up faster than I did. And what happens is that the longer they're in this period of self-reflection, that starts to significantly diminish their levels of self-compassion. And before long, these seeds of self-doubt are so flourished, they almost feel like they're flowering into perhaps they're not intended to be in healthcare after all. So it's real important to interrupt this phase if you can. If you see somebody that's intimately involved and they're alone, I was watching television the other night, a medical drama series, and the intern ran to the stairwell. And I thought, oh, she's intrusive reflecting. We need to interrupt her. But you can see it. If you start watching even the drama on television, it'll show it very nicely. And it's at that time that's just critical for institutions to start intervening. Restoring personal integrity can take a long time. It could take weeks, months, years, depending on the case. And what they worry about is that they fear the loss of being a trusted member of their team. They fear that they're not going to be able to be trusted anymore. And fear is prevalent. Who am I going to talk to? Is this going to be a lawsuit? There's so many questions. And so just having allies with the leadership team members as well as with their peers and kind of taking them under their wings, they realize that they're still an important part of the team, and that is so critically important in this phase. And during the Inquisition is they know that, especially with the case of a medical error, that they're going to have to start answering a lot of whys and a lot of information. And so this is really a scary, scary time for them. You'll see a lot of physical symptoms during this phase in particular. Active tears, wringing of hands, sweaty palms, red-faced, pale-faced. They're terrified of this experience. And you know, from a patient safety officer perspective, we try to do what we call a humane investigation, where in a just blame-free culture, we just ask for insights and have a conversation. But like the surgeon told me, whenever you pick up the phone and you get that call that Dr. such and such, do you remember Sue Scott? And your heart drops and you're immediately on the defensive. You're in the hot seat as soon as you get that information. So whatever we can do to try to provide a caring infrastructure, a humane investigation, we refer to them as case reviews now as opposed to investigations, just so that even the lexicon is important and can induce some stressful reactions for our caregivers. Obtaining emotional first aid is a fascinating phase, and one that definitely needs to have more exploration. But what we've learned is that as healthcare workers, we're great at being helpers, but as helpees, we're really poor. Only about 15% of healthcare workers will really actually reach out for help on their own behalf. And there's a lot of reasons behind that. A lot of it feeds into the stigma of reaching out for help, the perception of being considered a weak link. That's why I think it's important to have infrastructures in place that clinicians don't have to ask for help. Where they have to opt out as opposed to opt in, you might want to say. The next one, the sixth stage, is kind of unique. It's really more of an outcomes phase. And what we learned is that clinicians can actually move on in 3 different ways, meaning move on past that clinical event. They can thrive where that's our ultimate goal for every clinician that goes through these events. I found that if they could provide the supportive environment, give them the tools to figure out exactly what went wrong so we could fix it for the next patient and the next provider, that really promotes a healthy recovery. We always include them in our case reviews, our RCAs. I know that's a kind of a controversial subject, but what we found is if it really promotes healing when the clinician realizes that the fault isn't exactly on that clinician, but more on what that clinician felt and saw and perceived at the time, and what we can do to protect future patients from what had transpired. So thriving is the best way to recover. Surviving is, you've probably seen many people actually move on and just survive. They'll tell you that they can't put their heart on the line anymore, so they're a little more reserved, a little more tentative in their clinical interactions. The clinicians with this case have they have baseline performance, the event happens, their performance kind of plummets, and then they kind of heal, but they're never quite the same. And you might even be thinking of a colleague or coworker now that just probably is not quite the same. They just tend to be okay, and they don't want to put their heart on the line to hurt like they've just experienced. So they're a lot more cautious, a lot more kind of under the radar in a way. They almost become part of the wall. That concept is known as presenteeism. If you're familiar with that term, it's an HR term. Presenteeism is when you come to work and you're not quite feeling well, but you're there anyway. You know, if you have a little bit of an allergy or cold pre-COVID, if you come to work and just not feel well, you give it 110%, not your typical 150%. That's what the survivors look like. The more extreme outcome for second victims is what we call dropouts. And this is the group that I worry about the most. This is the group that, because of their clinical event, they transition. This one event is a tipping point in their career. And so they change that career somehow. It could be going to a different floor in the hospital in case of a nurse. For a pharmacist, it could be becoming a pharmaceutical sales vendor. For a surgeon, it could be going to bench research. Dropping out means that you're going to start all over. You're going to do something totally different. And I guess something I'd like to interject at this point is that this dropping out phase doesn't predict your future career success. What it does is it gives us an outcome on how well as an institution we supported that caregiver. Dropping out is really kind of worrisome to me. Many of you may have heard this name, Kim Hyatt. Kim is kind of an ultimate dropout. Kim was a nurse with 24 years of experience in a pediatric intensive care unit, and had taken care of her little guy for many, many days. So she started connecting with the patient. Pediatric case. The little guy had a significant cardiomyopathy at birth, and they were trying to grow him so that he could have a heart transplant. And he was having a very unstable day. They were ordering lots of verbal orders, kind of the perfect patient safety storm, you might want to say. And she gave electrolyte solution IV. And as soon as she gave it, she realized something didn't feel right. So she asked for a double check. And sure enough, she had given a 10-fold error in the administration of the medication. The little guy succumbed to his cardiomyopathy a couple days later, but it was precipitated by this drug overdose that Kim had administered. So this was before we really had strong peer support presence in our hospitals. And Kim was actually removed from care, went through a state board review, was removed from her position. The state board review told her that she could administer meds after reviewing the case, but she had to be supervised for any medication she administered by any RN, even a new grad that had just had a day's worth of experience. So Kim tried to find jobs, but it was such a publicly reported error that she wasn't able to land a nursing job. So she started working as a carpenter's assistant, and about 9 months after the event, she committed suicide because she realized that her heart was in healthcare and that she would never be able to go back again. So clinician suicides as a result of these events are not that common, fortunately, but they're common enough that there's a physician suicide blog that I've looked at. Because of the role that I'm in, I hear a lot of folks that are in the aftermath of a clinician suicide, and when they look at what infrastructure they have in their facilities, they're pretty bare. And so they're not as uncommon as you might think. We did a social media analysis of dropouts. They're hard to find. Once they drop out, HR can't give you their contact information. So we did a social media plea for a survey, and we had about 100 participants. Interesting findings. About 3/4 of them were inpatient care, which that's not really a shock. I guess I'm surprised it's not a little bit higher. That would infer that almost 1/4 are involved in the outpatient, ambulatory, pre-hospital transport kinds of settings. So that's important to think about when you offer supportive presence for your staff. It needs to be holistically all-inclusive. A large majority related to harm and death of a patient. Most of them were direct care providers, but the others were supervisory managers or instructors of students that were involved in mistakes. And then, not surprisingly, about 6 out of 10 assumed roles that wouldn't put their heart on the line again. It would be less risky exposure, that they wouldn't go through what they had just gone through. When asked, what would you identify as the major reason that you changed your role? And two were consistent. Inadequate lack of social support within their clinical environments, as well as the active influence of emotional labor by their supervisory personnel. Don't talk about this, keep this to yourself. Don't cry in front of the patient, don't show your emotion, kind of thing. And so those were the two main reasons that people felt the need to go to another role. We learned that second victims really want 5 things. They want to be appreciated, respected, valued, understood. Most of all, they want to be a trusted member of the team. And they fear that the most, that for some reason they're not going to be. The word cloud you see below is a compilation of some of our qualitative text from our qualitative interviews. The very last question we ask is, if your best friend would be going through a case similar to yours, what would you want to see done to help him or her? And so the bigger the word is, the more often it showed up. And you could see that some of them wanted immediate caring, support, guidance. They wanted just somebody to talk to in confidence about how they were feeling. And so if you could think of this mental image as you're either building a support infrastructure for your facility or dreaming of what one might look like, kind of think of this word cloud and to help guide some of those interventional strategies. The forYOU team is the name of the University of Missouri Healthcare's peer support model. Looks like a misspelled name, but it was actually designed purposefully by our steering team, one of our steering team members. She wanted a symbolic word, so one word, we're all in this together, so hence the forYOU's together. And she also wanted the you to be the focus. So the mantra of the team is, you've cared for our patients, now let's care for you. We took our about 4, or maybe I guess it was 5 research projects findings that helped inform the design of our team. We realized that we wanted to offer 2 specific interventional designs, peer-to-peer, one-on-one support, as well as when an entire team is impacted, to offer group debriefings. Then we also realized that we realized that some of the caregivers that we were providing care to had needs that exceeded capabilities of the trained peer supporters. And so we harnessed talents of some of our mental health professionals at our hospital to form what we call a tier 3. And so we could have expedited referrals for clinicians so that if they were in distress, they didn't have to wait. And so this was a coordinated effort. We used a 3-tier model, and you can see the 3 tiers there. And we'll go over just a little bit about each one. We had 3 team objectives. We review this on an annual basis, and we still have the same 3 objectives for our group. We wanted to figure out a way to minimize the human toll that we were seeing. We wanted to have a safe zone so people could talk and share their stories. It was interesting in our initial qualitative research, people felt safe under the IRB protected space that they could share their innermost thoughts about these cases. From some cases were decades ago. So we wanted to figure out how we could replicate that safe space for clinicians to be able to share what was kind of bothering them and just kind of get it out. And then last but not least, we wanted to be able to figure out a way to offer an internal rapid response infrastructure for our caregivers to offer emotional support. So peer support's been an interesting, looking at peer support's been interesting. And if you think of this as a sphere that's sliced open, when we first started offering peer support, we started it strictly for medical errors. And I realized very quickly that there's a lot of things that happen within the walls of the healthcare environment. There's a lot of unexpected patient outcomes with absolutely no clinical medical error involved, but that traumatizes our caregivers. So when we started the team, we deployed the team on March 31st of 2009. We were addressing those two types of clinical events. Within 3 weeks after starting the team, we had a suicide death of a young nurse, not related to anything clinically. And the manager said, I don't know how to put the group together. Is there any way you can help me? Plus, I'm pretty rattled as well. And so very quickly, within a month of deployment, we expanded our scope to include tragic clinician events, such as death of a coworker, helicopter crashes, ambulance accidents, those types of things. About 5 years ago, we started responding more and more to workplace violence exposures. About 1 in 5 of our encounters in 2019 related to one of our care team members being exposed to a violent event. Now, with the deadly pandemic, we've got the peer supporters really on overdrive almost. They're working on supporting their care team. This is very unique though, in that before they were external to most of these events. And now, as everyone's kind of going through the same stressors of COVID, it's really hard to be a supporter as well as also suffering yourself. So as we've evolved, we've realized that peer support is really generalizable, that we could actually tackle a lot of different types of distressed clinician scenarios through the skills of a caring peer. But what we need to do is, as we progress with each different type of scope, you might want to say, we need to make sure that those peers are armed. They've got the personal, interpersonal skills exceptional. What they need is the knowledge about each one of these different types of things so that they can be armed with a little more knowledge. We also learned that we had some limitations. Our success was pretty quickly known throughout the healthcare environment, and we started getting calls for help that really exceeded the capabilities of a trained peer, and they were turning towards the team leadership. And you could see some of the examples. We can't handle those kinds of things, but what we can do is we know where to turn those suffering caregivers. I referred to our mental health professionals that formed our Tier 3 support. Any one of those individuals could address any of these 6 scopes that are outside of our scope of service. And just to address a little bit about COVID, once again, peer support's generalizable. There's, this whole experience has really put the spotlight on healthcare, and it's really helped demonstrate a lot of our weaknesses and vulnerabilities within the healthcare system itself. And I believe that one of those weaknesses was the infrastructure of support that we have for our caregivers and ensuring the emotional well-being of our staff. So I think that might be one of the side effects, you might want to say, post-COVID, is that maybe that's one thing that's going to stick. We realize that healthcare institutions should have organizational support networks that complement the individual peer support. Peer support alone is awesome, but it can't take care of the whole system. We need to figure out how to complement their services with existing resources throughout our healthcare system. And I think it's critical that we provide resources to those peer supporters, knowledge and skills, debriefing the debriefer. They're stressed as all of us are. And so trying to have time to help support them is really, really important. So I guess if I needed to look at the definition of second victim that was coined in 2006, I think I would modify it to 2020 to say that second victims are any individual working within an environment to provide care and are traumatized by exposure to clinically challenging cases and events. I hate to not conclude without talking a little bit about the term second victim. It's actually become a bit controversial in some ways, in that patient family advocacy groups feel like we're trying in some way to equate their suffering with that of the clinician, especially in the case of a medical error. And so what we're trying to do is not do that at all, but we're trying to spotlight on the fact that we do need to have supportive infrastructures in place for our well-intended clinicians. These are some of the names that have been thrown around. My first manuscript that I wrote was Wounded Healer, and I had a surgeon tell me, don't sugarcoat it, that this hurts deeply, and second victim is what it should be. So I've been calling it that ever since. I think that term is short-lived. I'm not sure exactly what it's going to be. The military calls it collateral damage. Mental health professionals call it vicarious trauma. Got some hospitals that are referring to it as silent sufferers, which I'm not exactly sure what that even means. And then a couple places have referred to the forgotten victim. So we're not exactly sure. So the research, the primary international researchers on the topic wrote this article to just let people know that we're not happy with the name. We realize it's controversial. We realize that there's got a lot of different undertones to it. But at this point, we don't have a suitable alternative. And so if anybody listening has an idea, my email address is on the last slide. Please throw it out there to me, and I promise to give full credit to our research community. So Albert Wu, I referred to him earlier. He's a clinician at Johns Hopkins, and he actually coined the term second victim in 2000. But he recently said in a conference, and I think this is really important, it's not a matter of if clinicians are going to experience trauma while providing care, but when and how often. And I would add to his phrase, and how are you going to be ready to support them? It's interesting, you know, we've always thought of these as weaknesses and flaws, but as compassionate individuals who have gone into healthcare, we really kind of share the pain of those that we take care of. We strive for the respect of our colleagues, and if we lose that for any reason, we definitely suffer from that loss. As healthcare workers, we attempt perfection. In fact, where most all of us are perfectionists. It's painful when we can't live up to that expectation ourselves. Our calling into healthcare is to heal. The ideal that we have harmed an individual under our watch is totally devastating. So I'd like to just flip this paradigm totally around from weaknesses and flaws to say that these are virtues, not weaknesses. They're strengths, not flaws. They're part of being a human being. I know many of you might be in the safety, pursuing a high reliability organization. I just wanted to show you where in Sue's model of high reliability organizations where that might fit. But I think that clinician well-being, mental health and mental well-being in the form of clinician support is an incredibly important stepping stone in that patient safety culture evolution so that we can give perfect care every time to every patient. So I'd like to end with this one quote. I just love this. Helping one person might not change the whole world, but it could change the world for one person. And when we support our caregivers, we need to do it one caregiver at a time. So, Jody, I'll open it up for questions.
Fantastic. Thank you so much for outlining that. That's kind of really important. I think we've kind of touched on it, but never really gone in depth thus far about kind of second victim. I encourage people to chat in questions. I'm going to open up with a question. You know, you talked about kind of starting in 2009. So your organization has a bit of a head start here, moving into COVID, where you've been kind of doing this for now 11 years. And so what advice would you give organizations that might not be as far along in the path, but who now, because of COVID, are trying to ramp up efforts quickly? Are there things to focus on maybe that are more important?
So, you know, I think it's important to do an assessment of your internal resources. When we started, I knew that we had a social worker who was interested in grief counseling, and I knew I had a chaplain who was really good at crisis interventions. But as a whole entity, we really didn't have it inventoried or categorized on who were our resources and how can we harness the talents of those resources. So when the incident command was activated at University of Missouri, one of the first things they did was ask the forYOU team to start a clinician well-being effort. And we realized that it was bigger than just the forYOU team. So we harnessed a lot of talents. I think you need to think about pulling together as many resources as you can, because it does take a village to try to figure out how to promote mental health well-being during this period of time. The other thing is, there's so many resources, both internally as well as in your communities, that you might not think of. We turn to a lot of our religious leaders to have offer supportive presence that could be available. We actually divided our activities into opt-in activities and opt-out activities. When we were gearing up for the surge, we did a whole lot of opt-in activities, meaning the clinician themselves had to reach into, say, the menu and pick out what they needed to help. So they might pick out, there's lots of free apps that are available for both personal and professional resiliency. There's also different websites, the ANA, the AMA, they all have clinician well-being kits that have been formed. So I think that's why I think we're going to see a sequela after the COVID era is on mental health well-being. The other activity is to opt out. And so opt out means that it's presented to the clinician and they have to actually physically walk away from it. So that could include things like in your daily huddles to talk about a tip about personal resiliency. For so long, I think institutions have kind of pushed, especially just right before pre-COVID, we're pushing a lot of resiliency, but it was for the staff member to do things. And so now you could have roving people do like a mindful minute or positivity moment. We're doing kitchen chats where people can zoom in and just talk about what's bothering them that day. And so we're trying to be a little bit more invasive. We're trying to figure out a way. There's a, if you can think of, so positivity has been shown to be really important right now. And so there's three good things method that Dr. Brian Sexton developed at Duke. And so if you every day say what 3 good things happened to you today, that within 21 days, your mind actually rewires neurologically, and you can have a more positive outlook. And so we're thinking about how can we do 3 chimes and have everybody just pause for a second. What 3 good things have just happened to you this morning or tonight? And that would also engage the patient. So how we can, so at this point with the chronic kind of prolonged phase of COVID, we're looking at how to more opt-out opportunities than opt-in.
Fantastic. And we have a question. Carrie, do you want to unmute and ask your question?
Sure, I'd love to. Thank you, Dr. Scott, for being here today. You always do such a lovely job presenting. And I just was wondering, you mentioned the statistic of 15% of healthcare workers reach out.
Mm-hmm.
Do you feel that at your organization you have a higher rate of people reaching out because of the foundation you've created?
You know, so that's a great question, Carrie. Thank you. That was early on statistic. I bet it's a little bit higher now. I remember when in 2007, when I reached out to a young nurse who was involved in a pretty serious medical error and just asked her how she was doing. I got a very paranoid response. It was, "What are you doing? Call me. What have you heard? Is that grapevine active?" kind of thing. And when I told her no, and I don't have any questions about the case. I just was thinking about her and wanted to make sure she was doing okay, because I know how a case like that would impact me personally, and I wanted to make sure she was doing okay. And so now roll the clock ahead to 2020. She's still an ICU nurse, and if something bad would happen today and she wasn't getting what she thought was supportive presence, she'd call and say, "Now where's our support at?" so it's changed over time. But we've built these decades of reputation in healthcare where we kind of buck it up and keep on going and not talk about really what's bothering us. And so to change the culture, you have to change the habit. And so the habit that we introduced was our peer support team. And pretty soon those behaviors started changing. People not even on the team were helping each other out and knowing it was okay to reach out and say, "Hey, what can I do to help you?" And so it takes a habit to change the behaviors, and the behaviors ultimately make the new culture. of a supportive presence for everybody. So I believe that that's true, Carrie. I think that's probably a good observation. I haven't assessed that lately, though.
Thank you.
Mhm.
Thank you. And we have one more question. Dr. Scott, before Jeff asks the question, can you just unshare? I'm going to put out just some reminder slides
Okay.
while you get to this question. So you can just hit unshare the screen. And
Okay.
Jeff, do you want to unmute and ask your question?
Sure. Thanks, Jody. Hi, Dr. Scott. I'm Jeff Leichter. I'm a psychologist. I have a quick question. Within our health system, we have a formal clinician assistance program made up of mostly psychologists who are available for staff who may have any number of work-related emotional struggles. But we also have kind of a lower tier, what we kind of call executive coaches or paraprofessionals, organizational development. And they are often the first team that's activated to kind of do an assessment and intervene. And there seems to be a little tension between, where does the role of the paraprofessional or the peer support end, and what's the threshold for activating the professional mental health licensed clinicians? And it's a source of a little bit of friction about kind of who owns what. Do you have any thoughts about, when is it time to turn this over more to a mental health professional?
That's a great question, and you're blessed to have both resources in your facility. I have to admit that we've had the peer support team. We developed an Office of Clinician Wellbeing, and it's only for the medical staff, but it's mental health professionals, psychologists that's hired there. And it wasn't really until the COVID epidemic when we realized that we really needed all hands on deck that the two groups actually started formalizing conversations and providing probably stronger support for our caregiving team. And so we have like a little, we ask the tier 3 providers to share with our peer supporters, when's the best time to call me? And so they give little tips for, like, if it's a risk manager or if it's a social worker, a chaplain, or if it's a clinical psychologist. So it's actually been kind of a growing experience for us during COVID to identify, to get better at referring the mental health support. Looking at our 10-year data, it's about 13% of caregivers are referred to that tier 3, to the professionals. And I think that that's kind of helped when we started having the professionals come to our team meetings of peer supporters to get to know each other, as well as to talk about referrals that were made, and maybe even as the individual peers are talking about different support that they've offered, for the mental health professionals say, now see, this would be a perfect one to send to me, and this is why. So it's all of this is kind of a growing opportunity for everybody. You're blessed to have both resources. I'd figure out how to harness the two together and increase communication with the team members. I wish we had more clinical psychologists right now. That's an incredible resource.
Fantastic. Well, thank you, Dr. Scott. We're grateful for your time. We hope to kind of keep in touch and hear how things are changing. Just a quick reminder to those on the call, our playbook is online, so just visit ICSI.org. In 2 weeks, we have Dr. Jonathan Ripp from Mount Sinai, their Chief Wellness Officer, to talk about their experience in the COVID epidemic. So please join us then. And then I like to kind of have some meme to kind of bring a little bit of laughter. So school seems to be the buzzword right now. Everybody's stressed out about school. So here are my 2 memes related to school. If you like The Princess Bride, that's the lower one. And if you like The Lion King, that's the upper one. So trying to get the movie genres here. Again, Dr. Scott, thank you. You have her contact number. All of Dr. Scott's materials will be posted up on our website, so feel free to use them, as she said, and go to and refer to them. And we look forward to seeing you all in 2 weeks. Thank you, everybody.